Hi, my name is Terry Duran, and today we're going to give you some knowledge essentials, common resident healthcare conditions, and how you can care for those residents. The objectives of this course are to understand common health conditions of long-term care residents, identify how long-term care workers can help people with these health conditions, develop an understanding of the psychological impact of these conditions, and to raise awareness of other special healthcare needs of long-term care residents. In Texas, there are many assisted living residents. 46% are over the age of 85. 45% have Alzheimer's disease or other forms of dementia. Now, of these activities of daily living, 58% need help with bathing, 66% need help with walking, 46% need help with dressing, 37% need help with toileting, 30% need help with bed transfer, and 18% need help with eating. And who helps them with these tasks? That would be you, long-term care health workers. Now, in Texas, there are 1,300 assisted living communities with 48,700 beds. That would be a 29 average number of people served. Now, of all these people, 15% of residents rely on Medicaid for their long-term care. There are also community programs offered. 43% of these facilities provide social work programs. 51% provide mental health or counseling services, which actually is a little bit concerning. 66% provide therapy services, which also is concerning. 56% provide skilled nursing services. 60% provide hospice services. 42% provide dental services. 69% provide podiatry services. 83% have depression screening practices, which should actually be 100%. But only 28% serve only residents with dementia or have even a dementia care unit. I want us to understand aging. Aging is a process of gradual change over time that is most noticeable in children and older people. The human body reaches its peak physical functioning and ability in its 20s and early 30s. These are the years that the body is strongest, the senses are the keenest, and the mind is the sharpest. From there on out, the rate at which the body experiences age-related changes is quite individual, and it's often based on lifestyle, genetics, and the environment. It is important to understand that changes resulting from disease, so Alzheimer's or Parkinson's, or because of lifestyle choices such as lung cancer from smoking or cirrhosis of the liver from drinking excessively, are not a normal part of aging. I'm not going to talk about dementia care because that is in other requirements, but I want you to have a good understanding of the different types of dementia because that is not mentioned often. So a lot of people will tell me, I believe my father has dementia. And then I'll ask, what type of dementia? Oh, I don't know, just dementia. Or they'll say Alzheimer's. But what we need to understand that the word dementia is an umbrella term used to describe a range of conditions which causes changes and damage to the brain. So look at all these different types of dementia. So Alzheimer's disease obviously is the most common. But if you look, vascular dementia is also quite common, mixed dementia. And then you have these other types, which are smaller percentages. So Alzheimer's disease was named after a doctor, Dr. Alzheimer. In 1906, this doctor noticed changes in the brain tissue of a woman who had died of this unusual mental illness. Her symptoms included memory loss, language problems, unpredictable behavior, and after she died, he examined her brain and found these abnormal clumps. Now we call them amyloid plaques, and tangled bundles of fibers, which we now call tau tangles. These plaques and these tangles in the brain are still considered some of the main features of the disease. Another feature is the loss of these connections between nerve cells in the brain. So this is an irreversible, progressive brain disorder that slowly destroys memory and thinking skills and eventually the ability to carry out the simplest tasks. In most people with Alzheimer's, symptoms appear in their mid-60s. Experts suggest that more than 5.8 million Americans, and most of them 65 or older, may have dementia caused by Alzheimer's. By 2050, this number is projected to reach 14 million, and it is currently ranked as the 6th leading cause of death in the United States. Every 65 seconds, someone develops the disease, and it kills more people than breast and prostate cancer combined. So Alzheimer's, as you could see on the chart earlier, is the most common cause of dementia among older adults, and it accounts for 50 to 80% of dementia cases. So on average, a person with Alzheimer's lives 4 to 8 years after diagnosis, but can live as long as 20 years, depending on other factors. Now, my grandma was diagnosed with Alzheimer's in her mid-80s, and she lived until she was 98. So obviously, she does not fit this profile. So there's different stages of Alzheimer's. So you'll see the 7 stages of Alzheimer's. You'll see these 3 stages of Alzheimer's. And just to simplify it, I'm going to use these 3 stages. So the preclinical is not even really a stage, but this is kind of a stage before Alzheimer's. So you have these subtle changes taking place in the brain. So there may be difficulty remembering newly learned information because these Alzheimer's changes typically begin in the part of the brain that affects learning. You'll get these subtle personality, mood, and behavior changes. So family or others close to the person might notice symptoms, and the patient typically has an idea that something isn't right. Then they'll go into this mild stages of Alzheimer's. There will be difficulty learning new material, a decline in recent memory. There'll be this difficulty performing tasks. Somebody's appearance deteriorates. There'll be decreased concentration and judgment, time disorientation, difficulty finding words or naming objects. The resident usually is aware of their forgetfulness. They may withdraw socially, have feelings of shame, helplessness, and frustration may be seen. Residents experience greater memory loss and other cognitive difficulties. Problems may include wandering and getting lost, trouble repeating questions, taking longer to complete normal daily tasks, and the personality and behavior changes. And this is when people are often diagnosed. In the moderate stages of Alzheimer's disease, damage occurs in the areas of the brain that control language, reasoning, sensory processing, and conscious thought. Memory loss and confusion grow worse. People begin to have problems recognizing family and friends. They may be unable to learn new things and carry out multi-step tasks such as getting dressed or cope with new situations. In addition, people at this stage may have hallucinations, delusions, and paranoia, and may behave impulsively. Luckily, my grandma was actually a sweet Alzheimer's patient, so Alzheimer's resident. But she would have these hallucinations of the horses not being fed. So when my son and I would go to visit her, I would have to calm her down by saying, "Grandma, we fed the horses. Everything's okay, Grandma." In these severe Alzheimer's disease, ultimately these plaques and tangles spread throughout the brain. The brain tissue shrinks significantly. The last stage is almost complete deterioration of bodily function, personality, and behaviors. People cannot communicate and are completely dependent on others for their care. And again, in these late stages, in the severe Alzheimer's stage, my grandma couldn't even talk. She could just babble. But actually, it was okay. I would visit her with my son, and they would just babble together. So they had fun. Near this end, the person may be in bed most or all of the time as the body shuts down. So as you can see in this picture, we have this healthy brain, and then we have this severely shrinked Alzheimer's brain. There is no cure, unfortunately, to Alzheimer's. There's no prevention or treatment that can slow the progression of this disease. But there are 5 prescription medications approved by the FDA to treat its symptoms. I want you to understand that these current medications cannot stop the damage Alzheimer's causes to brain cells. They may help lessen or stabilize symptoms for a limited time because they affect certain chemicals involved in carrying messages among the brain's nerve cells. But doctors also can prescribe both types of medications together. Vascular dementia is the second most common cause of dementia among older people. Vascular dementia is a decline in thinking skills brought on by conditions that block or reduce blood flow to various regions of the brain, depriving them of oxygen and nutrients. So the whole mechanism or pathophysiology of vascular dementia is completely different of that of Alzheimer's. So these changes in thinking skills sometimes occur suddenly after a stroke, which blocks major blood vessels in the brain, or thinking difficulties may also begin as mild changes that gradually worsen as a result of multiple minor strokes or other conditions that affect smaller blood vessels, leading to widespread damage. So often, we talk about these unhealthy lifestyles and how it puts people at risk for cardiovascular events such as heart attack or stroke. But we never talk about the fact that those same lifestyles can also lead to dementia. So take uncontrolled diabetes, right? So uncontrolled diabetes, that high sugar, causes damage to the smallest blood vessels of your body. So a lot of times we focus on the feet, those being those smallest blood vessels. You can get a sore and it doesn't heal good because it doesn't have good circulation. But the same thing can happen. We also talk about the diabetic retinopathy of the eyes and those small blood vessels that can burst. But also that can happen in the brain. People have small blood vessels in the brain. So uncontrolled diabetes can actually lead to vascular dementia because people can have these small blood vessels that hemorrhage in the brain, and after it can cause microvascular disease that can lead to dementia and uncontrolled diabetes. Symptoms depend on the severity of the blood vessel damage and the part of the brain that it affects. So unlike other dementias, which tend to progress continuously, vascular dementia may progress in steps. So for example, the symptoms may worsen suddenly, then plateau or lessen somewhat. They may become worse months or years later, or it may be so subtle that dementia may seem to develop gradually and continuously instead of in steps. Memory loss, difficulty planning and initiating actions or tasks, slowed thinking, and a tendency to wander are similar to those of other dementias. However, compared to Alzheimer's disease, vascular dementia tends to cause memory loss later and to affect personality less. Vascular dementia tends to cause difficulty with the following earlier than Alzheimer's disease: planning and solving problems, handling complex tasks, and using good judgment, initiating actions, and thinking may be noticeably slow. About 6 in 10 people die within 5 years after symptoms begin, and this is often due to a stroke or a heart attack. Treatment is different. It focuses on managing the health conditions and risk factors that contribute to vascular dementia. So maintaining a healthy blood pressure, preventing and controlling diabetes. Of course, we need people to stop smoking, get physical exercise, and keeping the cholesterol in check. Mixed dementia is a condition in which brain changes of more than one cause of dementia occur simultaneously. In the most common form of mixed dementia, these abnormal protein deposits associated with Alzheimer's disease coexist with blood vessel problems linked to vascular dementia. And one study actually found up to 54% in autopsies. Alzheimer's brain changes can often coexist with Lewy bodies also, which we're going to talk about next. In some cases, a person may have brain changes linked to all 3 conditions. So Alzheimer's disease, vascular dementia, and Lewy body dementia. Researchers don't know exactly how many older adults currently diagnosed with a specific type of dementia actually have mixed dementia, but they're thinking it may be more common than actually previously thought. Lewy body dementia is again named after a doctor, Dr. Lewy. And he was a neurologist who discovered the hallmark abnormal microscopic deposits that damage brain cells over time in this type of dementia. And he was actually working with Dr. Alzheimer in his laboratory during the early 1900s. So alpha-synuclein protein, the chief component of Lewy bodies, is found widely in the brain in Lewy body dementia. And this type of progressive dementia leads to a decline in thinking, reasoning, and independent function. So Lewy body symptoms are thinking and reasoning, confusion, and alertness that varies significantly from one time of day to another or from one day to the next. So there can be slowness, gait imbalance, and other Parkinson's disease like movement features. They also, something very significant about this type of dementia is they have very well-formed visual hallucinations and delusions. They have trouble interpreting visual information. There can also be more sleep disturbances and malfunctions of the autonomic nervous system. Memory loss that may be significant, but it's also less prominent in Alzheimer's. In Lewy body dementia, there are no treatments that can slow or stop the brain cell damage caused by it. So current strategy focus on helping symptoms. They can try some of the Alzheimer's drugs, but they are limited in effectiveness. Like other types of dementia that slowly destroy brain cells, Lewy body dementia gets worse over time, and it also shortens lifespan. So it was also kind of funny because we saw our old neighbor at a baseball game, one of my son's baseball games, and he told us that he has Lewy body dementia, yet he seemed fine. But yet he told us his experience with Lewy body dementia, and his wife and his daughter were there and told us their experience with Lewy body dementia. And he told us that he sees hallucinations all the time. So he seemed normal. He remembered us. We talked to him. You could tell a little bit. He had some Parkinson's-like symptoms, And he was explaining us his experience with hallucinations. Like, he always sees things. So it was quite interesting. So as you look at the different types of dementia here, you can see that in Lewy body dementia, psychosis presents itself 75% of the time. And what we're going to talk about next is Parkinson's dementia is 50%. In Alzheimer disease, it can be 30%. And the lowest are the vascular dementia and the frontal temporal dementia. Lewy bodies are also found in other brain disorders, including Alzheimer's and Parkinson's. So many people with Parkinson's will eventually develop problems with thinking and reasoning, and many people with Lewy body dementia experience movement symptoms, such as hunched posture, rigid muscles, and a shuffling walk, and trouble initiating movement. So this overlap in symptoms with other evidence suggests that the Lewy body dementia and Parkinson's disease dementia may be linked to the same underlying abnormalities in how the brain processes this protein alpha-synuclein. So how they diagnose it, if you have the dementia first and then the Parkinson's shows up over a year later, they call it Lewy body dementia. If you have Parkinson's symptoms first, and then the dementia shows up later, they call it Parkinson's disease. So in Parkinson's disease dementia, there is a decline in thinking and reasoning that develops in many people living with Parkinson's at least a year after diagnosis. So again, differentiating between Parkinson's disease and Lewy body dementia. So this brain changes caused by Parkinson's disease begin in a region that plays a key role in movement, leading to early symptoms including tremors, shakiness, muscle stiffness, a shuffling step, stooped posture, difficulty initiating movement, and lack of facial expression. So as the brain changes caused by Parkinson's gradually spread, they often begin to affect mental functions, including memory and the ability to pay attention, make sound judgments, and plan the steps needed to complete a task. So again, these key brain changes linked to Parkinson's disease and Parkinson's disease dementia are abnormal microscopic deposits composed chiefly of this alpha-synuclein protein found wholly in the brain with a normal function which we don't really know. On this slide, you can see some of these symptoms: slowness of movement, speech changes, tremor. A lot of different regulatory functions in the body are also affected. Symptoms of Parkinson's disease dementia are changes in memory, concentration and judgment, trouble interpreting visual information, muffled speech, visual hallucinations, delusions, especially paranoid ideas, depression, irritability, and anxiety, sleep disturbances, including excessive daytime drowsiness and rapid eye movement sleep disorder. Again, there are no treatments to slow or stop the brain cell damage caused by Parkinson's disease dementia, so current strategies focus on improving symptoms. So again, the same drugs that are the current mainstay for treating the changes in Alzheimer's may help Parkinson's disease dementia. They certainly won't hurt. So they will basically just focus on improving symptoms. Now, there is something special with Parkinson's. Antipsychotic drugs used to treat behavioral symptoms should be avoided. About 60% of people with Parkinson's disease and Lewy body dementia experiencing worsening Parkinson's symptoms. So sedation, impaired swallowing, or neuroleptic malignant syndrome. Now, NMS is a life-threatening condition characterized by fever, generalized rigidity, and muscle breakdown following exposure to traditional antipsychotics. So Those, especially the traditional antipsychotics, should be avoided to treat behavioral symptoms in Parkinson's disease and Lewy body dementia. The last type of dementia we're going to talk about is frontotemporal dementia. And this used to be called Pick's disease, and this is named after another doctor, a Dr. Pick. And this is a physician who in 1882 first described a patient with distinct symptoms affecting language. And some doctors still use the term Pick's disease. So this type of dementia refers to a group of disorders caused by a progressive nerve cell loss in the brain's frontal lobes. So this is the lobe in the area directly behind the forehead, or its temporal lobes, the regions behind the ears. So this type of nerve cell damage, which affects those areas of the brain, causes problems in behavior, personality, difficulty with producing language or comprehending language. So it is much less common than Alzheimer's disease, but in younger age ranges, so 45 to 65, it is nearly as common as younger onset Alzheimer's. So only rough estimates are available, but there may be as many as 50 to 60,000 people with this type of dementia in the United States. And the majority of them are between 45 and 65 years of age. So there's different types of it, but the most common is behavior variant frontotemporal dementia. And this is characterized by prominent changes in personality and behavior. And this most often occurs in people in their 50s and 60s, but it can develop as early as people in their 20s or as late as in their 80s. And this is most prominent in areas that control behavior or judgment, empathy, and foresight, among other abilities. So the second form that is most common is primary progressive aphasia. And this is the second major form of frontotemporal degeneration. And this affects language skills, so speaking, writing, and comprehension. And this normally comes on in midlife before age 65, but it can occur in late life also. Before I get into the symptoms, I was watching one of these Karen videos about a year ago, and it made me think about these symptoms. It was a woman, she was in a store, and she behaved very inappropriately, and the video went viral. And her husband was there afterward, and he talked about her behavior, and he was so remorseful. And he said, I can't believe my wife was acting like this. A year ago, she would have never said or did those things. But her mental health has deteriorated, something to that effect. And it made me think that she might have this type of dementia. Because when a loved one says that they've never acted that way in their life, and they start to act a certain way, it makes me think that maybe this person was undergoing some type of dementia. So look at this. Increasingly inappropriate social behavior, loss of empathy and other interpersonal skills, such as having sensitivity to another's feelings, lack of judgment, loss of inhibition, lack of interest or apathy, which can be mistaken for depression, repetitive compulsive behaviors such as tapping, clapping, or smacking lips, a decline in personal hygiene, changes in eating habits, usually overeating, developing a preference for sweets and carbohydrates, eating inedible objects, compulsively wanting to put things in the mouth, speech and language problems, and movement disorders. Just to get you to think a little bit. So there's currently, again, no cure or specific treatment for this type of dementia. The medications to use Alzheimer's don't seem to be helpful in people with this type of dementia. and some may actually worsen this type of dementia. So certain medications or speech therapy can be helpful to manage symptoms. Again, the antidepressants can help some of the behavioral symptoms. Sometimes the antipsychotics are sometimes used to combat the behavioral symptoms. However, these medications, again, need to be used with caution. So unfortunately, it does inevitably get worse over time, and the speed of decline really differs from person to person. The care of people with dementia is covered in other required trainings. So we're not going to get into that in this teaching, but we are going to get into that as we cover the most common chronic conditions among residential care facility residents. So let's look at them. High blood pressure, Alzheimer's disease, and other dementias, heart disease, depression, arthritis, osteoporosis, diabetes, chronic obstructive pulmonary disease, and other conditions which would affect the lungs, cancer, and stroke. And let's start with high blood pressure. Let's start with number 1 on the list. Hypertension is the medical name for high blood pressure. It affects about 1 in 3 adults in the United States, and despite it being so common, more than 50% of these adults don't have it under control, and 20% don't even know that they have it. And the stakes are very high. High blood pressure is a major risk factor for heart disease and stroke, both of which are leading causes of death in the United States. The good news is that high blood pressure or hypertension can often be prevented or treated. There are risk factors that can be changed, and there are risk factors that cannot be changed. Risk factors that cannot be changed include a family history of high blood pressure. Somebody can't change their age if they're over 65 years of age. One can't change coexisting diseases such as diabetes or kidney diseases. But there are risk factors for high blood pressure that can be changed. Unhealthy diets such as excessive salt consumption, a diet high in saturated and trans fats, low intake of fruits and vegetables, physical inactivity, smoking, being overweight and obese. While some people with high blood pressure get headaches, neck pain, or chest pain, most people do not even feel any symptoms. And that is why high blood pressure is sometimes referred to as a silent killer, and it can be deadly. About 70% of people who have had a heart attack for the first time, and about 80% of people who have had a stroke for the first time have existing high blood pressure. Blood pressure is recorded as 2 numbers. The systolic blood pressure, or the first number, indicates how much pressure your blood is exerting against your artery walls when the heart beats. Most studies show a greater risk of stroke and heart disease related to higher systolic pressures compared with elevated diastolic pressures. The diastolic blood pressure is the second number. It indicates how much pressure your blood is exerting against your artery walls while the heart is resting between beats. According to recent studies, the risk of death from heart attack and stroke doubles with every 20 millimeter systolic or 10 millimeter diastolic increase among people from age 40 to 89. This is our most recent blood pressure guidelines or charts. You can see when somebody's blood pressure, their systolic, which again is that first or upper number, gets to the point where it is between 130 and 139, and their diastolic between 80 and 89, it is considered stage 1 hypertension. 140 or higher, systolic, 90 or higher diastolic is considered stage 2 hypertension. But if your systolic gets higher than 180 and your diastolic gets higher than 120, that is called a hypertensive crisis. And somebody needs to consult their regular healthcare provider immediately, or they need to get sent into the emergency room. Unfortunately, even in most healthcare offices, blood pressures are not taken correctly. So let's go over the American Heart Association guidelines for how to take a correct blood pressure measurement. Ideally, the patient or the resident shouldn't eat or drink anything 30 minutes before the blood pressure is taken. Ideally, the resident should empty his or her bladder before the reading and ensure at least 5 minutes of quiet rest before measurements with no talking while it is being measured. The resident also should sit correctly. So they should sit with the back straight and supported, ideally on a dining chair. Their feet should be flat on the floor and their legs should not be crossed. The arm should be supported on a flat surface such as a table, with the arm at heart level. Make sure the bottom of the cuff is placed directly above the bend of the elbow. Measure at the same time every day. It's important to take readings at the same time each day, such as morning and evening. It is best to take readings daily, however, ideally beginning 2 weeks after a change in treatment and during the week before the next appointment. Take multiple readings and record the results. Each time it is measured, take 2 or 3 readings, 1 minute apart, and record the results. And don't take the measurements over close. So don't just bunch up their sweater or bunch up their shirt. The cuff should be against bare skin. Now let's talk about recognizing a hypertensive urgency or emergency. So there are 2 types of hypertensive crises, and both require immediate evaluation to determine the appropriate course of action. A hypertensive urgency is defined as 2 consecutive blood pressure readings of 180 over 120. So a systolic of 180 and a diastolic of 120 or greater, confirmed at least 5 minutes apart without symptoms of target organ damage. So this would be symptoms of chest pain, shortness of breath, back pain, numbness, weakness, change of vision, or difficulty speaking. So what you would want to do in this situation is notify the medical staff, so the primary care physician, and await further instructions. The PCP would need to manage this blood pressure, but this situation doesn't usually require hospitalization. A hypertensive emergency is defined as a blood pressure reading of 180 over 120 or greater, with associated symptoms of target organ damage such as chest pain, shortness of breath, back pain, numbness, weakness, change in vision, or difficulty speaking. And this requires immediate evaluation. So 911 should be called or direct transportation to the emergency room. So what can we do to help residents control their blood pressure? Of course, encourage residents to stop smoking. In fact, it is illegal to smoke in most long-term care facilities in most states. Some, such as the Veterans Administration facilities, will have outdoor designated smoking areas, but each cigarette they smoke increases their blood pressure for a long time after finishing. And quitting helps blood pressure return to normal and reduces the risk of heart attack and stroke. And of course, we know people who quit smoking live longer than people who never quit. Help residents reach and maintain a healthy weight. So losing even a small amount of weight if they are overweight or obese can help reduce blood pressure. In general, this reduces blood pressure by about 1 millimeter of mercury with each kilogram. So this is about 2.2 pounds of weight lost. Eating a healthy diet that is low in saturated and trans fats and rich in fruits, vegetables, whole grains, and low-fat dairy products. Eating healthy can lower blood pressure by up to 11 millimeters of mercury if one has high blood pressure. The aim to consume less than 1,500 milligrams per day of sodium. Even a small reduction in the sodium in the diet can improve heart health and reduce blood pressure by about 5 to 6 millimeters of mercury. So the type of diet, the National Heart, Blood, and Lung and Blood Institute recommends the DASH eating plan. So DASH is an acronym that stands for Dietary Approaches to Stop Hypertension. So probably people in the long-term care facility will be on the DASH diet. So you can have a look at that, or you can actually look that up. Limit alcohol intake if the facility allows it to no more than 1 drink per day if the resident is a woman, or 2 drinks a day if the resident is a man. Alcohol can be both good and bad for health. Encourage the resident to be physically active. Add muscle strengthening activity at least 2 days per week for more health benefits. Make sure the resident takes their medicine as directed, and routinely check the resident's blood pressure correctly now that you know the guidelines. Report to the nurse or healthcare personnel any abnormal readings, again, now that you know how to take blood pressure correctly. Let's move on to heart disease. So heart disease basically describes a range of conditions that affect the heart. So heart disease includes blood vessel disease, such as coronary artery disease, and this can lead to heart attack, heart rhythm problems, so these are called arrhythmias, heart defects that one can be born with, so these are called congenital heart defects, heart valve disease, disease of the heart muscle, or heart infection. The blood vessels of your heart are called coronary arteries. A buildup of fatty plaques in the arteries of your body is called atherosclerosis. And this can happen anywhere in the body. But when it's in the heart, it is called coronary artery disease. So this buildup of fatty plaques can damage the blood vessels of the heart. This plaque causes narrowed or blocked blood vessels that can lead to a heart attack. Now this plaque buildup, of course, is caused by lifestyle factors. So bad eating habits, obesity, lack of exercise, etc. But we're not going to get into all of that right now. Signs and symptoms of coronary artery disease can include chest pain, chest tightness, chest pressure, and chest discomfort. And this is called angina because the heart is not getting enough oxygen. It causes this pain. It can also cause shortness of breath, pain in the neck, jaw, throat, upper abdomen, or back. One might not even know they have coronary artery disease until they actually have a heart attack or have an attack of angina or heart failure itself. An arrhythmia, the heart may beat too quickly, too slowly, or irregularly. Heart arrhythmia signs and symptoms can include a fluttering in the chest, a racing heartbeat, a slow heartbeat, This can cause chest pain or discomfort. This can cause shortness of breath, lightheadedness, dizziness, fainting, or near fainting. These are the more common types of arrhythmia. Atrial fibrillation. Many people don't even know they're in atrial fibrillation when they have it. But this can cause strokes. Atrial tachycardia. Ventricular tachycardia and ventricular fibrillation are actually shockable heart rhythms. Those are life-threatening. But this is what we use those external defibrillators to shock people for. Cardiomyopathy is basically an enlarged and diseased heart. In early stages of cardiomyopathy, one may have no symptoms, but as the condition worsens, symptoms may include breathlessness with activity or at rest, swelling of the legs, ankles, feet, fatigue, irregular heartbeats that feel rapid, pounding, or fluttering, dizziness, lightheadedness, and fainting. There's also valvular disease. The heart has 4 valves, the aortic, mitral, pulmonary, and tricuspid. And these valves open and close to direct blood through the heart. Many things can damage the heart valve that lead to narrowing, which is called stenosis, leaking, which is called regurgitation or insufficiency, or improper closing of the valve, which is called prolapse. So depending on which valve isn't working properly, valvular heart disease signs and symptoms generally include fatigue, shortness of breath, irregular heartbeat, swollen feet or ankles, chest pain, or fainting. The end result of many of these diseases can be congestive heart failure. Heart failure develops when the heart cannot pump as much blood as the body needs. It cannot keep up with the body. The tissues of the body don't get enough oxygen and nutrients. Muscles may be fatigued and organs may not function normally. Fluid may accumulate in the abdomen, legs, feet, and lungs. Over time, the heart can no longer keep up with the typical demands placed on it to pump blood to the rest of the body. I used to work in heart transplant 20 years ago, and it was so fascinating to see when the old, floppy, huge hearts would actually come out of the body, and they would be placed on the operating room table, and you would see this old, diseased heart be replaced with a new, healthy, smaller heart. And actually, when the old heart would come out of the body, sometimes it would still be beating. When you placed it on the table, it would beat for a couple minutes. Sometimes, yeah, you could actually touch it, and it would start beating again. So to see it replaced by a healthy heart, but it just kind of gets big, and it's called cardiomyopathy. It gets big and diseased and doesn't function like it should. The symptoms of heart failure can be ongoing, so chronic, or they may be sudden or acute. Shortness of breath with activity or lying down. There can be fatigue and weakness, swelling in the legs, ankles, and feet, which we call edema. The heart rate can be irregular or rapid. They won't be able to exercise very well. It's called exercise intolerance. There can be a cough or wheezing with white or pink blood-tinged mucus, swelling in the belly, very rapid weight gain from fluid buildup, nausea and a lack of appetite, difficulty concentrating or decreased alertness, and chest pain if sudden heart failure is caused by a heart attack. Treatment of heart failure involves a plethora of medications. The resident may also have a pacemaker and an internal defibrillator. So naturally, as you'd expect, if somebody has an internal defibrillator At some point, it may actually deliver a shock to the heart. Some patients describe it as being hit by lightning or walking into a lamppost or being kicked in the chest by a horse. So sometimes a defibrillator might need to shock the heart multiple times to restore a normal heart rhythm. Some patients may also describe seeing a flash of light with patterns, sometimes resembling lightning. So be prepared for that. So if it does shock, you will need to notify the healthcare staff as soon as possible, especially if it shocks multiple times. Because if it's a shockable heart rhythm, they may need to call 911 or at least call the patient's healthcare provider. The doctor also may recommend including palliative care in the resident's treatment plan. Palliative care, it's important to understand that it's completely different from hospice care. Palliative care can be part of hospice care, but palliative care is specialized medical care that focuses on easing symptoms and improving the quality of life of the resident. Anyone who has a serious or life-threatening illness can benefit from palliative care, either to treat symptoms of the disease, such as pain and shortness of breath, or to ease the side effects of treatment, such as fatigue or nausea. It's possible that the resident's heart failure may worsen to the point where medications are no longer working. And if this occurs, then the resident may need hospice care. So in staff considerations, fatigue and shortness of breath may cause the residents to take more time to do things and will cause them to tire very easily. So give them enough time in their daily activities. Also, any direct care staff should report any new symptoms or symptoms that get worse and document this according to facility protocol. This may also affect residents psychologically, so how they relate to themselves and socially, how they relate to others. They may have anxiety that they're going to have a heart attack. They may also restrict their activities or isolate themselves. They may have even anxiety that their ICD may go off. They may be depressed about having a chronic health condition. They may be concerned about incontinence, because some of the medications, such as the diuretics, will cause them to urinate a whole lot more. They may feel isolated if they need frequent or even sometimes they need constant oxygen. Depression is the most common mental health disorder in older adults, but it is not a normal part of aging. Studies show that most older adults feel satisfied with their lives, actually, despite having more illnesses or physical problems. Depression is classified under mood disorders, which are characterized by disturbances in the regulation of mood, behavior, and affect that go beyond the normal fluctuations that most people experience. Depression will affect 7% of older adults around the world at least once in their lives, and 1/4 of suicides involve people aged 65 years or older. Depression is also underdiagnosed and undertreated in primary care settings. Late life depression affects about 6 million Americans ages 65 or older, but only 10% get treatment. Symptoms are often overlooked and undertreated because they co-concur with other problems encountered by older adults. Older people with depressive symptoms have poorer functioning compared to those with chronic medical conditions such as lung disease, hypertension, and diabetes. And depression also increases the perception of poor health, the utilization of healthcare services, and costs. So what are some depression misconceptions? Older adults, as well as family and friends, often believe that depression is a normal part of aging. And as a result of this misconception, Friends and professionals do not always look or listen for warning signs when an older person may be feeling desperate. There's also stigma. Many older adults hide their true feelings and thoughts from their physician, family, and others because they're embarrassed, fear they will be negatively judged. And in our Western society especially, there's a lot of ageism. Our Western society tends to value younger people more than older adults. My husband, being from Venezuela, has taught me a lot about honoring our elderly parents. And if we look at Asian society also, they tend to honor older adults. But in our Western society, we tend to value younger people more than the older adults. Some older adults are hesitant to share their thoughts of suicide, erroneously thinking that nobody will care about their suffering or their future. Depression symptoms can be unique in the elderly. There can be a persistent sad, anxious, or empty mood, feelings of hopelessness, guilt, worthlessness, or helplessness, irritability, restlessness, or having trouble sitting still, loss of interest in once pleasurable activities, decreased energy or fatigue, moving or talking more slowly, difficulty concentrating, remembering, or making decisions, difficulty sleeping, early morning awakening or oversleeping, eating more or less than usual, usually with unplanned weight gain or loss, thoughts of death or suicide attempts, aches or pains, headaches, cramps, or digestive problems without a clear physical cause and or that do not ease with treatment, and frequent crying. Treatment choices really differ for each person, and sometimes multiple treatments must be tried to find one that works. Psychotherapy. There are a number of evidence-based psychotherapeutic treatments for adults with major depressive disorders, such as cognitive behavioral therapy. Medications. Studies have found that while antidepressants can be helpful in older adults, they may not always be as effective as in younger patients. And also the risk of side effects or potential reactions with other medications must be carefully considered. For example, certain older antidepressants such as amitriptyline and imipramine can be sedating, which may cause confusion, or might cause a sudden drop in blood pressure when a person stands up. This can lead to falls or fractures. Electroconvulsive therapy is a highly effective treatment for depression, and there can also be simulation techniques. So all healthcare staff need specific education and training on depression and how to recognize and treat it. Because recognizing and adequately evaluating the symptoms of depression are indispensable aspects of healthcare monitoring for ensuring that old adults receive quality services and that their preferences and needs are met. Early diagnosis promotes early and optimal management. Also protect the resident's right to autonomy. Autonomy is often used interchangeably with the experience of having choices and being in control. When long-term care residents feel that they have control over their activities, this has a positive influence on their health and well-being. Provide for the residents' physical needs, assist with self-care and personal hygiene, and make sure they're getting enough to eat. Plan activities for times when the resident's energy level peaks. Assume an active role in initiating communication. This can be done by sharing observations of a resident's behavior, speaking slowly and allowing ample time for the resident to respond, encouraging him or her to talk and write down feelings, and by providing a structured routine, which may include non-competitive activities. Avoid false cheerfulness, and don't hesitate to laugh with the resident and point out the value of humor. Educate the resident about depression. Explain that depression can be eased by expressing feelings and engaging in pleasurable activities. Emphasize that there are effective methods available for relief of symptoms. Ask the resident whether they think about death or suicide. Signal an immediate need for consultation and assessment. Stress the need for medication compliance. Review adverse effects with the resident. Evaluate the resident's ability to identify ineffective coping behaviors and consequences. Meet the physiological needs. So this would be evidenced by the appropriate expression of feelings, identification of options, and the use of resources. And evaluate the support system available, the specific referrals made, and who is responsible for actions to be taken. According to the Center for Disease Control, and this surprised me when I read it, older men have the highest suicide rate of any age group. Men over 85 years of age have a suicide rate of 45.23 per 100,000 compared to an overall rate of 11.01 per 100,000 for all ages. Suicide attempts by older adults are much more likely to result in death and are less likely to be discovered than younger adults. And older adults make up 12% of the U.S. population, but account for 18% of all suicide deaths. There's really few reliable statistics on suicide in long-term care facilities. But there's a researcher named Brianna Mezuk, an associate professor of epidemiology at the University of Michigan. And in 2015, she found that the rate of suicide in older adults in nursing homes in Virginia was nearly the same as the rate in the general population, despite the greater supervision in these facilities. So they presented some research at the 2018 Gerontological Society of America annual meeting. And their team looked into roughly 50,000 suicides among people 55 and older in the National Violent Death Reporting System from 2003 to 2015 in 27 states. They found that 2.2% of those suicides were related to long-term care. The people who died were either living in or transitioning to long-term care or caregivers of people in those circumstances. So 47% of these cases occurred among persons anticipating or in the process of transitioning into residential long-term care. So research shows events like losing a spouse or a new cancer diagnosis put people at higher risk of suicide. But close monitoring requires resources that facilities just don't have. Nursing homes already struggle to provide enough staffing for basic care. Assisted living centers that promote independence and autonomy can also miss warning signs of suicide risk. So suicidal signs and symptoms in the elderly include death, dying, or suicidal poems, notes, or journal entries. So this is something that you can all be looking for. Taking unnecessary risks, being reckless or impulsive. Neglecting physical appearance. Failure to take care of themselves or follow medical orders. Unusual or unexpected visits or calls to family and friends, saying goodbye to people as if they won't be seen again. An inability to concentrate or make decisions. Talking about or seeming preoccupied with death. Constant thoughts of death or hurting oneself. Statements like, I wish I were dead, or I can't take this life anymore. I mess up everything I do. You would be better off without me. There is no hope. Things will never get better. I'm not sure I'll be around. Poor sleeping patterns, nightmares, loss of appetite or increased appetite, experiencing dramatic mood changes, not deriving pleasure from or losing interest in activities, hobbies, or socializing with friends. A sudden sense of calm and happiness after being extremely depressed can mean that the person has made a decision to commit suicide. Giving away personal items and saying goodbye to loved ones, and getting one's personal affairs in order, such as finances or wills. All healthcare staff need specific education and training on suicide risk and how to recognize and intervene. Always stay with the resident or call another employee or family member to stay with them and alert the nurse that they are experiencing suicidal ideation. Suicide is an impulsive act with little or no warning. Provide a safe environment and remove any potential harmful objects that the resident could use for self-destructive purposes. Arrange for the family to stay with the resident. A hospitalization is considered if no one is available, especially if the person is highly suicidal. And follow facility policy and procedures that should already be in place for suicide risk. And there are many suicide crisis helplines, and here are just some of the few that are specific for the elderly. There's the National Helpline Network, the National Suicide Prevention Hotline, the Center for Elderly Suicide Prevention, and the Lifeline Crisis Chat. The next health condition we're going to talk about is osteoarthritis. Osteoarthritis is the most common cause of chronic disability in older adults. It is a slowly progressive degenerative disorder of the articular joints that has multiple etiologies, so multiple causes, with age being a key factor. This disease affects both men and women. Before age 45, osteoarthritis is more common in men than in women, and after age 45, osteoarthritis is more common in women. Commonly affects the hands, the knees, the hips, and the spine, with knee osteoarthritis presenting a major cause of pain and activity limitation. Osteoarthritis occurs when the cartilage, so this is a soft tissue that cushions the ends of the bones within the joints, and this breaks down and it wears away. In some cases, all of the cartilage may wear away, and that's when you hear people say it's bone on bone, and these bones rub up against each other. So this is not simply a process of wear and tear, but rather an abnormal remodeling of joint tissues driven by a host of inflammatory mediators within the affected joint. So symptoms of osteoarthritis are joint stiffness, most noticeable upon wakening and after being inactive. Joint tenderness, loss of flexibility. There could be a grating sensation, a popping, or a cracking. Bone spurs can form around the affected joint, and swelling can be caused by soft tissue inflammation around the joint. Arthritis of the spine may show up as stiffness and pain in the neck or lower back. In some cases, arthritis-related changes in the spine can cause pressure on the nerves where they actually exit the spinal column. And this results in weakness, tingling, or numbness of the arms and legs. In severe cases, this could even affect bowel and bladder function. In the knees, which are one of the most affected joints, symptoms can include stiffness, swelling, and pain, and this makes it hard to walk, climb, and get in and out of chairs and bathtubs. In the hips, This may limit moving and bending, and so this makes daily activities such as dressing and putting on shoes a challenge. In the hands, people can get these small bony knobs that may appear on the end of the joints of the fingers, called Herbert's nodes. Similar knobs called Bouchard's nodes can appear on the middle joints of the fingers, and the fingers can become enlarged and gnarled, and they may be stiff, and they can ache, and they can get numb. And the base of the thumb joint is also commonly affected by arthritis. But arthritis can affect any joint in the body. It can also affect the shoulders. That would probably be the next one. So treatment for arthritis is to manage the pain and improve function. So people are recommended to avoid activities that make the pain worse or overloading the joint. So there's exercises that can be done to improve strength. So there's exercises that include both aerobic and resistance training that have been shown to decrease pain and improve physical function in multiple trials and should be encouraged by healthcare providers regularly. A physical therapist can show the resident exercises to strengthen the muscles around the joint, increase flexibility, and reduce pain. Regular gentle exercise that people can do on their own. Swimming is perfect for people with arthritis, and that can be equally effective. People can unload the joints by using a brace, a splint, or a cane or a crutch. An occupational therapist can help the patient discover ways to do everyday tasks without putting extra stress on the painful joint. Weight loss is huge because our bodies are not made to handle obesity. So each pound of weight loss can decrease the load across the knee 3 to 6-fold. So in our country, unfortunately, there's kind of an epidemic of morbid obesity and morbid obesity, but our joints are not made to handle that much weight. So unfortunately, we're having a lot of problems with osteoarthritis, a lot of pain issues. There's also those TENS units. This uses a low voltage electrical signal to relieve pain. It provides short-term relief for some people, especially those with knee and hip osteoarthritis. It can also help the back a lot too. Arthritis treatment. Unfortunately, there's nothing magic that you can do to heal it. So people are stuck in the beginning with just taking over-the-counter pain medications. So for the elderly, Tylenol is going to be the safest. But it's not very effective for severe pain, but people can take it for mild to moderate pain. And if people have liver damage, they of course need to be careful and they can't take too much or it will actually cause liver damage. The NSAIDs are medications like naproxen or ibuprofen, which would be your Advil and Aleve. And unfortunately, they can cause other issues such as stomach upset, heart problems, bleeding problems, liver and kidney damage. So those have to be used with caution in the elderly. But there are gels that can be used on the skin, which are safer. So they have fewer side effects and can relieve pain just as well. Duloxetine is another option, especially if there's a depression as well. That is an antidepressant and it has also been approved by the FDA for osteoarthritis. There are cortisone injections that are used a lot to help relieve pain. However, these are self-limiting because they can only be injected a certain amount of times each year, and it can actually worsen joint pain over time. There are some lubrication injections. There is a procedure called radiofrequency ablations where they actually go in and they actually burn the nerves that are causing the pain. This can be very effective in some people. So it is most commonly used to treat chronic pain and conditions such as arthritis of the spine. but it can be used to treat neck, back, knee, pelvic, and peripheral nerve pain. And finally, joint replacement. And in joint replacement surgery, the surgeon actually removes the damaged joint surfaces and completely replaces them with plastic and metal parts. Residents with arthritis will probably require more time performing daily tasks, especially in the morning when those joints are stiff. The joints tend to be more stiff in the morning, and as the day goes on, they tend to loosen up. So help residents try to be as independent as possible. Sometimes assistive devices are needed and the correct shoes. Assistive devices includes things such as walkers and canes and other assistive devices like grabbers and gadgets, and we're going to talk about that in just a minute. These devices can help someone to be independent when arthritis makes it difficult to do everyday things. So watch for changes and report them, and notify a supervisor, especially when a resident has uncontrolled pain, because there's so many things that can be done to control pain, and nobody should have to live in uncontrolled pain. So especially when they're having trouble moving also. So arthritis can impact a resident psychosocially, as in addition to physically. So this means that it affects them psychologically, how they relate to themselves, and socially, how they relate to others. So chronic pain is no joke. It can result in depression. It's no fun to be in pain all the time, and they have trouble moving around. So it may cause residents to reduce their socializing. It takes longer for them to get moving. They need more rest. So again, it is imperative that osteoarthritis patients have a pain management plan as part of their care plan. So this is a good time to talk about assistive devices. Assistive devices are mechanical items that help a resident. So as care providers for residents, these are things that can help them perform activities of daily living without an individual's physical assistance. And use of assistive devices promotes independence. So there are different types and uses of assistive devices. There are assistive devices that are used for mobility. So these are assistive devices are used so that residents can ambulate or walk from one point to another without assistance or with minimal assistance. These include canes, a walker, or a wheelchair. In toileting, assistive devices are used so that residents can empty their bowel or bladder without assistance or with minimal assistance. A bedside commode is very helpful because many people need to get up during the night. So if they have a bedside commode at their side, they can maybe easier get up during the night, just go use the restroom in the bedside commode and get back in bed. So this would just require then the emptying of the bedside commode in the morning. Also raised toilet seats, having grab bars beside the commode, and even having a toilet tissue aid. There are also a plethora of assistive devices for eating. So these assistive devices are used so that a resident can eat without assistance and will not need to be fed by another individual. So there are specialized knives, spoons, and forks made to fit the resident's hands. There are also plates and bowls with suction cups to prevent diningware from falling off the table, and plates with curved edges to keep food on the plate. There are also cups with straws for ease in drinking. There are assistive devices that are used so that the residents can pick up items that are on the floor or on a shelf without assistance and to reduce fall risk. So there are grabbers and reachers. Writing, there are assistive devices that allow residents to write letters or sign checks or just for general communication. So this is an example of a writing bird. For dressing and grooming, assistive devices are used so that the resident can engage in fine motor skill activities like dressing and grooming without assistance. So a sock donner or a zipper pull, a button threader, a dressing stick, a long-handled comb and a brush, a long-handled shoehorn, elastic shoelaces. So there's many things that can be used for grooming and dressing. Showering and bathing. Assistive devices are used so that the resident reduces the risk of falling and also maintains dignity by being able to bathe without supervision. So a shower chair, a shower bench, having grab bars in the shower, having a handheld shower massager, a long-handled bathing sponge, a hair washing brush. So in transferring, there are assistive devices used so that a resident can transfer from one place to the other. So the bed to the chair or the chair to the commode with reduced assistance. This reduces the resident fall risk as well as the risk for resident and staff injury. So you've got a transfer board and also Hoyer lifts. Let's move on to osteoporosis. Osteoporosis means porous bone. Calcium and other minerals give bone a honeycomb type appearance under a microscope, which gives bone its strength. In osteoporosis, the branches of the honeycomb are thinner, broken, or just simply missing altogether. In osteoporosis, the bones have lost the minerals that kept them strong. It is a disease characterized by low bone mass and structural deterioration of bone tissue. This means the bones become fragile and they become easy to break. Commonly, this occurs in the spine, in the hip, and in the wrist. And it is often silent until an actual fracture occurs. Approximately 10 million Americans already have the disease, and another 44 million are at high risk for it. The U.S. Surgeon General reports that nearly half of all women older than 50 will experience a fracture because of osteoporosis, and up to 1 in 4 men. So there are several complications of osteoporosis. There is height loss and posture that is stooped and hunched. This happens because the vertebrae begin to break or they actually collapse. 25% of seniors who break a hip die within 1 year from problems related to the fracture itself or the actual surgery done to repair it. And many of those who survive actually need long-term nursing home care. So signs and symptoms, there are often no signs and symptoms until the disease is severe. Back pain caused by a fractured or collapsed vertebrae, loss of height over time, a stooped posture, that posture that you could see on the slide before, which is called kyphosis, bones that break easily. As far as treatment, we have medications, so bisphosphonates. However, there are some serious side effects related to those types of medications. There are several injections that can be done. There's hormone-related therapy, bone-building medications, and also some supplements. So most healthcare providers will have people on calcium and vitamin D supplementation and also have them eating a well-balanced diet rich in calcium and vitamin D. As far as staff intervention, again, we have a lot of chronic pain. So pain may cause residents with osteoporosis to do less or to do things more slowly. So give them time to perform those activities. Bone tenderness may make everyday activities such as bathing even painful. So consider how you can provide a gentler way of helping them with these activities. A huge thing is to prevent falls. So residents should wear low-heeled shoes with non-slip soles, and caregivers should adhere to all fall risk training requirements. And again, report any uncontrolled pain, and of course, pain management should be part of the care plan. Let's move on to diabetes. So when we think about diabetes, we're going to focus right now on type 2 diabetes. So diabetes is a chronic metabolic disorder characterized by persistent hyperglycemia, or a persistent high blood sugar. It may be due to impaired insulin secretion resistance to peripheral actions of insulin, or both. Approximately 1/4 of people over the age of 65 have diabetes, and about 1/2 of older adults have pre-diabetes. Older adults with diabetes have higher rates of premature death, functional disability, accelerated muscle loss, and coexisting illnesses such as high blood pressure, that we talked about, coronary artery disease that we talked about, stroke, which we're going to talk about, than those without diabetes. Older adults with diabetes are also at greater risk than older adults for several common geriatric syndromes, such as polypharmacy. So polypharmacy is somebody who's taking a lot of different medication. Cognitive impairment, depression, which we already talked about, urinary incontinence, falls, and persistent pain. Diabetes 2 used to be known as adult onset, but both type 1 and type 2 diabetes can begin during childhood and adulthood. Type 2 is more common in older adults, but the increase in the number of children with obesity has led to more cases of type 2 diabetes in younger people. So type 2 diabetes is primarily the result of two interrelated problems. So the first part is insulin resistance. So the cells in muscles, fat, and the liver become resistant to insulin. So insulin is produced by an organ in the body called the pancreas. So the pancreas may be producing enough insulin, but the cells in muscle, fat, and liver become resistant to the insulin. And because these cells don't interact in a normal way with the insulin, the response to the insulin is diminished. So during this state, insulin is basically ineffective and initially is countered by an increase in insulin production to maintain glucose homeostasis. So this pancreas is working really hard to produce more insulin. So after a while, the pancreas starts to kind of give out, and there is impaired insulin secretion. So this production in insulin decreases because the pancreas is unable to produce enough insulin to manage these blood sugar levels. So the result of this is people feel thirsty. They urinate a lot. They feel hungry. They can have unintended weight loss. They can feel tired. They can have blurred vision. They may get a sore and it doesn't heal very quickly. They can have frequent infections, especially yeast infections, numbness or tingling in the hands and feet. So a position statement issued jointly by the American Diabetes Association and the European Association for the Study of Diabetes recommends a 4-step approach to type 2 diabetes treatment. So when it's first diagnosed, they recommend lifestyle changes, plus a medication called metformin. So this metformin is known to decrease that insulin resistance. And then, of course, the lifestyle changes of exercise and diet. If the lifestyle changes and the metformin aren't enough, then add a second medication. The choice of the agent is made in light of relative efficacy, the risk of having low blood sugar, what is tolerated, weight-related considerations, and cost. So if that doesn't work, you go to step 3, to a 3-drug combination, and they try to include metformin. Again, the choice of the regimen is determined based on the drug and patient-specific considerations. If step 4 doesn't work, if this 3-drug combination doesn't work, then they go to an insulin, a 24-hour insulin, to achieve treatment goals after 3 to 6 months. So, and if not, that doesn't work, then people just go on insulin. So for the elderly, however, it is a little bit different. So older adults who are otherwise healthy with few coexisting chronic illnesses and intact cognitive function and functional status should have lower glycemic goals. So we try to keep their blood sugars at about 7.5. Older adults with multiple, so the A1C is a blood level that's measured every 3 to 6 months in people with diabetes. And that's the main thing that is tested. Those goals tend to be higher, or are recommended to be higher for the elderly, the older people are. Older adults with multiple coexisting chronic illnesses, cognitive impairment, or functional dependence should have less stringent glycemic goals, or less stringent A1C goals. The goals for some older adults might reasonably be relaxed as part of individualized care. But also, having too high of blood sugar can lead to symptoms or risk of acute high blood sugar complications and should be avoided in all patients. So we don't want to let them go too high either. Treatment of high blood pressure to individualized target levels is indicated in most older adults. And treatment of other cardiovascular risk factors, so should be individualized in older adults considering the time frame of benefit. Also, lipid lowering therapy, so cholesterol, and aspirin therapy benefit those with life expectancies at least equal to the time frame of primary prevention or secondary intervention trials. So aspirin, it really depends because aspirin can also cause bleeding. Also, some of the cholesterol medicines can cause some muscle aching and weakness factors. So you always have to look at benefits versus risks in people. And as you can see, we have these lovely algorithms for the treatment of diabetes. And of course, I'm not going to get into this. I just wanted to show you that. So for healthcare providers, these are very helpful. We also have the simplification of complex insulin therapy, other algorithms that are available. There are many complications that are associated with uncontrolled diabetes because that high blood sugar destroys the nerves and the blood vessels of the bodies. So you could have poor circulation caused by blockages in the arteries. So those very small blood vessels behind the eyes can actually hemorrhage, and it can cause blindness. There can be poor blood flow resulting in kidney failure. There's nerve damage due to high blood sugar causing damage to those very small nerves in the feet and the hands. So people can lose sensation, or they can have a lot of pain, or anywhere in between, and that is called neuropathy. People can have lack of circulation to their feet, so they can have foot infections and ulcers when not enough blood reaches to the feet. So especially in the feet, they may get a cut, and because of the nerve damage, they don't actually feel that they got it. And because of the lack of circulation, that cut may not heal up and they can get an infection. A reason why the A1C goal levels are higher in the elderly is because a common clinical problem in elderly patients or residents with diabetes is hypoglycemia or low blood sugar. Signs and symptoms of low blood sugar include sweating, shakiness, weakness, hunger, irritability, dizziness, headache, blurred vision, heart palpitations, slurred speech, drowsiness, confusion. They can look pale. If a resident has these signs and symptoms of low blood sugar, it's important to go get a monitor and check it if you are trained, or find somebody that can. If their blood sugar is low, then they should be given something to eat or drink that will quickly raise their blood sugar levels. So fruit juice or a sugar tablet, a glucose tablet, a piece of hard candy, or some other source of sugar. And then they should have their blood sugar checked in about 15 minutes. And if their levels are not increasing or not at target, or they're just not feeling better, then that sugar intake should be repeated. Now, if the patient is back to those target levels, then they should eat a normal meal after their levels return to normal. If the resident for some reason loses consciousness, they will need to be given an emergency injection of glucagon. This is a hormone that stimulates the release of sugar into the blood, and this would be given by the nurse. General interventions would be to monitor the resident's blood sugar levels. So the A1C is something that's checked every 3 to 6 months. But what you check when you're checking with the machine or the blood glucose monitor is the glucose level. So that should be checked anywhere from 1 to 4 times a day, sometimes not even that much. It just depends on the resident. So it depends. If the resident is supposed to check it themselves, then just every once in a while, you should be checking their numbers. They should have a notebook that they write it down in, but you have to kind of check that they are checking it without offending them. If the staff is checking it, then just make sure that those blood sugar levels are within the target range. The direct care staff should also report any observation of a diabetic resident's feet for any signs of wounds, infection, and document this according to the facility protocol. And this should be in the care plan, that there should be inspection of the resident's feet. Diet restrictions also may result in a decreased interest in eating. So if somebody is in transition, they've just transitioned from their home into long-term care, there's going to be diet changes. So with these diet changes, there may be requirements or changes in their diabetic regimen. So if they were eating a very high calorie diet and then they come into long-term care and this changes, they are at high risk for hypoglycemia. So they may need to back off on some medications or back off on some insulin. So that needs to be watched, especially when they come into that transition. Or say somebody gets an insulin shot of their short-acting insulin. So this acts very quickly within a half hour or an hour. So say it's breakfast and they just don't feel like eating that morning, but the nurse gave them their insulin. Well, unfortunately, they have to eat. If they don't eat, they're going to have a hypoglycemic episode. So those patients should have special monitoring to make sure they eat. There's also some psychosocial implications. So like we talked about, diabetes comes with a lot of different complications. So people can be blind or have be on dialysis from kidney failure. So there can be a lot of depression and anxiety over being chronically ill or having multiple chronic conditions. Chronic obstructive pulmonary disease is the next one we're going to talk about, and this is called COPD. And it is characterized by progressive airflow limitation and tissue destruction in the lungs. And this is associated with structural lung changes due to chronic inflammation from prolonged exposure to noxious particles or gases, most commonly because of cigarette smoke. It can be other things, but 80 to 90% of COPD cases is because of tobacco smoke. So this causes airway narrowing and decreased lung recoil. It is a disease state that is not fully reversible. Asthma is not considered part of COPD because asthma is reversible. Chronic bronchitis is a chronic inflammation of the lower respiratory tract characterized by excessive mucus secretion, cough, and shortness of breath associated with recurrent infections of the lower respiratory tract. Emphysema is a complex lung disease characterized by damage to the gas exchanging surfaces of the lungs or the alveoli. So again, exposure to tobacco smoke accounts for an estimated 80 to 90% of all COPD cases. And you can see the difference between a healthy and a COPD lung. Again, I used to work in cardiothoracic surgery. So when I look at this picture, it doesn't really do it justice, because when you would look at a smoker's lung, it would truly be black. So look at a nice healthy lung. It's this nice pink, whitish color. But a COPD or a smoker's lung would actually be like this grayish black color. As far as COPD complications, there is respiratory insufficiency and respiratory failure. And of course, these are the major life-threatening complications. But people can get pneumonia and frequent respiratory infections. There is right-sided heart failure because after circulation goes through the right side of the heart, it actually goes up into the lungs. And this resistance can cause the right side of the heart to actually fail. There's also pulmonary hypertension, pneumothorax, skeletal muscle dysfunction, depression, and anxiety disorders. Symptoms of COPD are chronic cough. This chronic smoker's cough with copious amounts of sputum and phlegm. Shortness of breath, especially when they're up walking around. And this shortness of breath may be so severe that they can't even do anything, and it interferes with their activities. Now, we can't blame these patients too much, because back in the 30s and 40s is when smoking really became a popular fad. But it wasn't until the late 1950s and early 1960s that they began to see the effects of it. It was a cardiothoracic surgeon that noticed, hey, all of my lung cancer patients are smokers. Then they began to research it, and by the 70s is when it began to come out. Hey, this is dangerous. This is killing people. So it wasn't until the 1980s and 1990s that things began to change. But unfortunately, you had a whole generation that was addicted to cigarettes. And even during the Vietnam War, they would give out cigarette packets as part of the rations. So unfortunately, we have this generation of Vietnam veterans that became addicted to cigarettes during the Vietnam War. So some of those you're going to see that are now in their 70s and 80s in long-term care. even in the Veterans Administration long-term care facilities. The treatment objectives for COPD are to relieve symptoms. So we have inhalers, medications, nebulizers, and oxygen therapy. We want to prevent disease progression. So no matter how many years they've smoked, we still want them to stop smoking. The most essential step in any treatment plan for COPD is smoking cessation. Reduce mortality and improve exercise tolerance. Pulmonary rehabilitation is indicated in all stages of COPD. It is a comprehensive plan that is tailored to patients that may involve therapies such as some exercise training, education, and behavioral changes. Its purpose is to improve a patient's physical function and psychological condition. Prevent and treat complications. There is an antibiotic that is sometimes used. It's called azithromycin. And this has been shown to reduce the number of exacerbations in patients with COPD. There's also some procedures that can be done. And I'll just mention these. One is called a bulectomy, and another is called a lung volume reduction surgery. Staff interventions. Follow infection control guidelines to prevent the resident from getting sick, and monitor the resident for any signs and symptoms of illness, such as fever, worsening cough, body aches, etc. Watch for shortness of breath. The resident may have pursed-lipped breathing, inability to speak or converse. Note the presence and degree of shortness of breath. Reports of feeling hungry for air, restlessness, anxiety, respiratory distress, use of the accessory muscles, and report any changes in their status. Evaluate their level of activity tolerance. Provide a calm, quiet environment. Limit the patient's activity or even encourage bed or chair rest if they become short of breath. And have the patient resume activity gradually and increase that as individually tolerated. And always let the nurse or other healthcare staff know, because sometimes, as far as medications go, these residents can be managed a lot better. There's some really new and good medications out there. And I'll find that a lot, that people's medications can be managed a lot better. So evaluate their sleep patterns. So note reports of difficulties, whether the patient feels well rested, provide a quiet environment, group care, or monitoring activities to allow periods of uninterrupted sleep. So limit stimulants such as caffeine in the afternoon, and encourage a position of comfort. Now is a good time to talk about oxygen therapy. Oxygen therapy is a treatment that provides the resident with extra oxygen. This is a gas that the body needs to work properly. So oxygen is supplied in a metal cylinder if they're going to be walking around, or an oxygen concentrator. It flows through a tube and is delivered to the lungs in one of two ways: through a nasal cannula, which is the most common. This has two small plastic tubes that are placed in both nostrils, or through a face mask that goes over the nose and mouth. So oxygen must be prescribed. So the source of the oxygen, so it must be compressed gas or concentrators, and the delivery service. So this would be through a nasal cannula or the mask. Now this must be written on the prescription along with the flow rate. So a respiratory therapist may also help a person understand how to use their oxygen. So the oxygen helps by decreasing the resident's shortness of breath, decreasing fatigue, and improving sleep. Oxygen can pose a fire hazard. The cylinder that oxygen comes in can explode when exposed to heat. So it's important that you follow the instructions from the oxygen provider on safe handling of the oxygen. So in Iraq, recently, 92 people died on a COVID ward in an oxygen tank explosion. So never store compressed oxygen gas cylinders and liquid oxygen containers in small enclosed places such as closets, behind curtains, or under clothes. Direct care staff responsible for the care of a resident using oxygen must have training or instruction in the use and maintenance, including routine cleaning of resident-specific equipment and oxygen. So other safety tips for people who are using or working around people with oxygen are, of course, don't smoke or be around people who are smoking. It was kind of funny because I used to work on a heart ward or a heart floor, and people would smoke in their rooms sometimes or try to sneak a smoke, and you could smell it, and you'd walk in the room and it'd be all smoky, and you'd ask, are you smoking in here? And they'd be like, no, I'm not smoking. And of course, there's oxygen in the rooms, right? So you'd be like, oxygen is flammable and you can't smoke up here. You can go outside, but, it's just kind of funny. Anyway, it just brought back that memory to me. Never use paint thinners, cleaning fluids, gasoline, aerosol sprays, and other flammable materials. And stay at least 5 feet away from gas stove, candles, and other heat sources. A sign stating no smoking, oxygen in use must be present in all locations where oxygen is used, including resident room doors and common dining and activity areas. This is done to enforce the smoking prohibition in any area of the building in which oxygen is in use. Only oxygen in a portable source may be used by residents in assisted living when outside their rooms. Long plastic tether lines to the oxygen is prohibited because this creates a fall risk for those around the tether lines. So we're not going to talk about cancer because there's so many different types of cancer and the treatments are so different. So we're just going to move on to stroke. So strokes are serious and can be deadly. Being familiar with the signs of stroke and responding quickly can save the older adult's life or reduce their chance of developing major disabilities. Stroke is the 5th leading cause of death in the United States, affecting about 800,000 people each year. It also causes more serious long-term disabilities than any other disease. If a blood vessel in the brain ruptures and affects neurological function, this is called a hemorrhagic stroke. When a blood vessel in the brain is occluded or blocked by a clot and neurological function is affected, this event is called a ischemic stroke. The signs and symptoms of a stroke can happen very quickly and with little warning. The victim seems confused and cannot speak, or his or her speech is garbled. One side of the victim's face droops, and he or she has serious weakness in the hands, arms, or legs. The loss of blood to the brain causes brain cells to die. The body parts that these cells control become damaged as a result. This may include paralysis, speech problems, memory and reasoning deficits, coma, and possibly death. A stroke causes permanent brain damage. However, people who have strokes may be able to regain function through rehabilitation. There's an algorithm developed by the American Heart Association called ACT FAST. So, face droops, arm weakness, speech difficulty, time is critical. So call 911. After a person has had a stroke and leaves the hospital, a program of rehabilitation may begin to help the person regain some of their lost abilities. So this may include physical therapy, occupational therapy, and speech therapy. Individuals may also have depression. So they may be in long-term care temporarily. People recover most quickly in the 30 days after a stroke and then continue to recover at a slower pace over a period of months. People who have had strokes may use assistive devices to help them get around and perform daily activities. People who have had a stroke are at risk of having more strokes, so they must be monitored. Staff interventions include improving mobility and preventing deformities. So position the resident to prevent contractures, use measures to relieve pressure, assist in maintaining good body alignment and prevent nerve damage, apply a splint at night to prevent flexion of the affected extremity. Establish an exercise program. Now, usually the occupational therapist and the physical therapist will do this at first, but provide full range of motion 4 to 5 times a day to maintain joint mobility, regain motor control, prevent contractures in the paralyzed extremity, increase strength, and enhance circulation. Also observe for signs and symptoms of a blood clot to the lungs or excessive heart distress during exercise, so shortness of breath, chest pain, monitor their pulse rate. Supervise and support the resident during exercises, so plan frequent short periods of exercise, not longer periods. Encourage the resident to exercise the unaffected side at intervals throughout the day. Encourage personal hygiene activities as soon as the resident can sit up. Select suitable self-care activities that can be carried out with one hand. Make sure the resident doesn't neglect the affected side, so provide assistive devices as indicated. Improve morale by making sure the resident is fully dressed during activities. Assist with dressing activities, so maybe have clothing with Velcro closures. Put the garment on the affected side first. Keep the environment uncluttered and organized. Provide emotional support and encouragement to the resident when they are feeling fatigued or discouraged. Assist with nutrition, so observe the resident for coughing fits or food dribbling out or pooling in one side of the mouth. So food retained for long periods in the mouth or nasal regurgitation when swallowing liquids. Have the patient sit upright, preferably on a chair, when eating or drinking, and advance their diet as tolerated. Some residents may have lost bowel and bladder control, so assist the male resident to an upright posture for going to the bathroom. Establish a regular time, for example, after breakfast for toileting. Improve communication. Establish goals together with the resident. Make the atmosphere conducive to communication, remaining sensitive to the resident's reactions and needs and responding to them in an appropriate manner. And above all, treat the resident as an adult. Provide strong emotional support and understanding to allay anxiety. Avoid completing the resident's sentences. Be consistent in schedule, routines, and repetitions. A written schedule, checklist, and audio tapes may help with memory and concentration. A communication board may be used. Maintain the resident's attention when talking. Speak slowly and give one instruction at a time. Allow the resident time to process. Talk to aphasic residents when providing care activities to provide social contact. And help facilitate family coping. Provide counseling and support to the family. Involve the family members in the resident's care. Teach stress management techniques and maintenance of personal health for family coping. Give the family information about the expected outcome of the stroke and counsel them to avoid doing things for the resident that he or she can do. Develop attainable goals for the resident at home by involving the total healthcare team, resident, and family. And encourage everyone to approach the resident with a supportive and optimistic attitude, focusing on abilities that remain. And explain to the family that this emotional ability usually improves with time. I was thinking about this today, but you as long-term care workers are an essential part of the resident care team. You not only provide physical care for residents, but also emotional and spiritual support, truly making a difference in their lives and in the lives of their families. You are the eyes and ears of the clinical staff, observing the residents carefully and making sure the healthcare team knows any changes. You spend more time with residents than any other team members. You get to know them, answer their questions, talk to families. You are on the front line of care. You impact resident outcomes by performing primary patient rounds or demonstrating good listening skills and addressing needs. You develop trust from residents that impact how they perceive their overall care. And I am truly sorry that you are undervalued and under-celebrated and underpaid, because you truly deserve to be valued and celebrated. So I don't know, go give yourself a hug or something. I'm not sure, but now it is time to take your quiz. And I celebrate you today also. All right, you all have a good day. Thanks. Bye-bye.